Dr. Naresh, we are live, I think.
Yes, sir. Yes. Sir, we are live. Dr. Abhijit
Yes,
is, yes. Good evening, all. Welcome to the IAS Academic Corner, July 23. Today, we have with us Dr. Sujit Jose, sir, and Dr. Ajay Chinchole, both as moderators. And expert talk will be given by Dr. Samir Sheikh, and as well as two case presentations by Dr. Tushar Doke, as well as Dr. Abhijit Sen. Over to you, Dr.
Good evening. Good evening.
Sujit Jose, sir.
Yeah, I'll take the honors of starting the meeting. Welcome all. We have very eminent faculty here. Dr. Samir Sheikh, I think, is the first person to multiple number of lateges, and I heard him present 30 cases of arthrolatege when I was just starting my lateges. So he, I think, has the maximum number in India. And it is nice. Yes, like yesterday we had in the discussions in Arthroscopy Academy, in other parts of the world, people are doing lateges for even 0% bone loss, and that is being announced. Like, we are very like hesitant in like doing lateges and arthrolateges. We choose and pick and choose our cases 20%, 50% bone loss. But then there is a section of the world where, or more sections of the world where arthrolatege is considered to be the gold standard for all dislocations, even with no bone loss, and especially in people where the athletic activity or the high performance is more required than our weekend warriors or the people who play badminton or lighter sports like in our part of the world. So let us start our talk. Let me ask Dr. Ajay to put in a few words, and we'll start the meeting with Dr. Samir.
Good evening, everyone. Very nice topics today and eminent faculties. Without, I think, wasting much time, we should start the sessions.
Okay. Thank you.
So first, I think Dr. Samir sir is going to share his talk.
I will share my screen.
Yeah.
Can I share my screen, Naresh? Okay.
Please go ahead, Dr. Samir.
Yeah. Yeah. So today's topic, arthrolatege, is very near to me. And thank you, Sujit, for the beautiful introduction what you gave. But I know now you are doing more numbers. Arthrolatege now you have started doing with Smith and Nephew. Just there can be a conflict between you and me today, like which is better. So just let's start now with arthrolatege, the how I do the arthrolatege, and the few tips and tricks I would like to share with you people. And as you all know, I have started my arthrolatege since 2013 in almost, and 2013 up till 2019 I'm having the data, and last 2 years yet we have not collected further. So almost we have completed our cases, more than 140 cases now. And 108 cases what we were having, or 4 live surgeries were included in that, and 52 cases were done for primary anterior Bankards with glenoid bone loss more than 20%. And 36 cases what we have done for primary anterior Bankards with glenoid bone loss more than 20% and off-track Hill-Sachs lesion, which is sufficient large. And in 19 cases, what we have done are for the failed arthroscopic Bankards, that is soft tissue capsulolabral repair initially has been done with capsular deficiency. And 1 case was failed open Bankard repair, or for which we have done it. And we have published our data of 74 patients and seen what we had completely with all patients. And now we are in a process to publish for 140 patients. Let's see how it goes. Now, why lethargy? As just now Dr. Sujit said, like it's very important, like bone loss, it's almost certain in all the cases if you see. And arthroscopic Bankard, it was a gold standard for anterior shoulder instability, but it fails in certain situations like glenoid bone defects more than 20%, capsular insufficiency is there, Hegel lesion is there, large engaging hill sacks is there, or the young patients who are overthrowing or the overheads or the throwing athletes are there. In such patients, usually we need to think whether just the arthroscopic Bankart repair is going to give a good result or not. That is a topic of discussion. So why now arthroscopic Lataje? Why not the open Lataje? Initially, when we started in 2002, when we started with open Latajes. But if now arthroscopic Lataje can give the comparable results as open Latajes, why not to do arthroscopic Lataje? And it's having a superior cosmosis, minimally invasive it is, faster recovery is there, less chances of stiffness is there. Even if you can see better visualization of the anatomy, more precise graft positioning can be done with this. And even most importantly, the concomitant abnormalities such as the slap repairs, if it is there, any other pathology, rotator cuff injury is there, you can deal with this. Even remplissage you can add along with that, Lataje, if you want really. The most important concern is the anterior-inferior glenoid bone loss. If this anterior glenoid bone loss, if it is more than 20%, that's what up till now I have done. But now recent papers have come up which they are showing like it's almost now people have started doing it for 13.5% also. So let's see, wait and watch. But at present, glenoid bone loss more than 18 to 20%. I am doing arthrolatages and how we assess the glenoid bone loss. If you see the glenoid bone loss to assess, we'll not go into the details of this, but just 3D CT and the MRI is most important thing what we need, and the best fit circle method what we are using for on the 3D CT, as well as we always compare it on the other side. And my radiologists, they give us the whether it's off track or hill sacks depending on the CT scan, and I have a rough idea about that. And even interop, we do an arthroscopic assessment for that to find out whether really this off-track hill sack is there or the on-track hill sack is there. Then accordingly we decide whether to go ahead with the arthroscopic Lataje. Anyway, we are doing in a beach chair position for this. So as we discussed now, glenoid bone loss more than 20%, whether it's on-track hill sacks or off-track hill sacks, I will go ahead and do arthroscopic Lataje. And if arthroscopic Lataje or the Lataje fails, only option left with us is the arthroscopic or the open bone block using the autologous iliac crest bone grafts. Now, positioning what we give for such patients is a beach chair position, general anesthesia usually with interscalene block and a suprascapular block. This is must what we do. And for the portals, what we inject is the adrenaline, xylocaine with adrenaline, just to avoid bleeding over there. And portals, routine portals, what we use was what the Laurent Lafosse he uses. That is the first is our viewing portal, posterior viewing portal is there. Second portal what we use is the D portal, what I have shown it here. That is the anterolateral portal. And another viewing portals are the J portal as well as the I portal, which is in the axilla. And if you see this M portal, if it's far more medial in line with the glenoid, bone it is there, so that when we are passing a graft from anterior aspect, it should go and hit the anterior aspect of the glenoid properly. And that is more important. It is lower down. And H portal, if you'll see this H portal is nothing but for the placement osteotomy of the coracoid, as well as to put the alpha beta zig over there. And the E portal, if you see, this is the rotator interval portal, which we start with initially. So in short, we'll discuss the few tips and tricks, how we go ahead with the procedure. First step, what we do, we have divided our steps into 10 steps usually. The first step, what we do first is the joint evaluation, what we do. In the joint evaluation, for the most important thing part, if you see, is whether it's off track, on track, is there, what is the condition of the soft tissue. That is the more important part. And after once we have done the joint evaluation and we have decided to go ahead with the arthrolataje, then in a beach chair position, we first create a, as I said, a E portal, rotator interval portal. And from the rotator interval portal, we start Now, there are certain concerns like whether to do anterior capsulectomy or not whether not to do, whether yes to do. We do it. Just now we have started repairing the bankards also along with that. But in initial days, this is the video where we started at removing the capsule initially from 2 o'clock to 5 o'clock. And if you see that 2 o'clock to 5 o'clock capsule, what we release and we keep it aside, and then further we can attach it to the but frankly speaking, out of my 140 cases, in 120 cases or 124 cases, you can say we have not done a bankart repair after doing in the lethargy procedure. Almost. And after doing this capsule release from the 2 o'clock to 5 o'clock, and then after releasing the capsule, we mark for the graft placement at present now only, so that in further, once that extravasation starts and the ballooning of the shoulder starts, it's very difficult to find and where we are. So first step is shoulder exposure and the preparation, what we do here. And after releasing the capsule as well as the labrum from 2 o'clock to 5 o'clock and keeping aside, so that in further we can take one bite for that and do a arthroscopic bankart repair if we need it. But Laurent Lafosse, he says there absolutely there is no need for that. And even we have seen few cases as post-operative post-ops after 2 years, where we can't even differentiate whether capsule what we have removed it has it's there or not. But we don't know. Let's see. And the glenoid bed preparation is the next step. What we do after releasing the capsule, you can just do a bed preparation with the help of the shaver, with the help of the cautery, and release everything so that some space is created anteriorly. So that when I come from the subscap split, it's a bit easy for me to place the graft perfectly at 5 o'clock to above. So usually I place my graft up from 5 o'clock above, so that I should not be more inferior, so that my screw which goes distally, that should be at least have a purchase of both the cortexes, and I should get enough good rigid fixation for that for the screw. So that I start usually at 5:30 to 5 o'clock, and above that we go, right? The next step after the glenoid bed preparation, and we are weaving now through from the anterolateral portal, which is a D portal, what you can say, an anterolateral portal we are weaving, and still my quadri, it is in the E portal, that is a rotatory interval portal. And now what we'll do is we will try to locate. Now you just orient yourself like from the anterolateral portal I am weaving, you can see the subscap on the left side, and my RF is in between the conjoint tendon and the subscap. And here I will just try to find out where the axillary nerve is there. Definitely it will be helpful when I'm splitting the subscap, because once if I isolate the axillary nerve here, you can see I'm going far medial, I am above the subscap, and you can just find out where your axillary nerve is there. You can feel it. The axillary nerve, once if you have seen where it is, in this case, it's far more medial, also that my split will be an easier one. But there are certain instances where I'll tell you, sometimes this axillary nerve is far more or lateral. So that time it becomes very difficult to do a subscap split. That's why the Laurent Lafosse and other peoples, they are doing the subscap split in the end. They do a coracoid osteotomy first and then do the subscap split. But that again differs surgeon to surgeon. We have modified ourselves. We do subscap split first and then we do the coracoid osteotomy. For that sake, now if you can see the dead in front of me is the axillary nerve. What I am just feeling it. No need to peel it off, but just for demonstration, and we are doing this because this was the live surgery what I did it 3 years back, and we were demonstrating the axillary nerve which is there in front of. That's why just otherwise no need to dissect it. Once the axillary nerve has been found out where it is there, the other important step is now try to locate the coracoid. And once the coracoid has been located, after locating the coracoid, you start releasing the CA ligament. The CA ligament, and you can see we are releasing the CA ligament, and we are making ourselves comfortable to have all the glenoid coracoid at superior surface. We are preparing it properly, And once the CA ligament release is, you can just retract it with one stick, and then you will have a good view for that. Here now we have started using the 70-degree scope also here, so that I can see dead up to the base of the coracoid easily, because sometimes it becomes difficult. Even when I start from the posterior aspect, we do with the 70-degree scope also to visualize. Here, in fact, we are in the anterolateral quarter. After CA ligament release, everything has been done. Now the next step, what we do, CA ligament release has been done, and now what we do is a subscap split. This subscap split, if you'll see, we have started after locating the axillary nerve, we have started medially, and then subscap split is very important, because once if you are doing a subscap split properly, that is wide enough, and you are reaching up to the glenoid properly, then your graft placement will be a very easy thing once if you are done a coracoid osteotomy. And then after a subscap split, we can
pec minor, right?
Yes,
this is the pec minor which I have released it, but I have not released it completely yet. Okay, I wanted to split the subscap first, then I want to come here. So I have kept it here. It's a very vascular bundle. You can see this. This is the plexus. Initially, I have dissected musculocutaneous nerve and separated out, right?
Yes.
Now this is the brachial plexus, which is here. And if you want, I can dissect for you. You can see this?
Yes.
I am feeling it now with me.
So musculocutaneous nerve identification is also very important here. Once if you locate the musculocutaneous nerve here and pec minor release has been done, then your life becomes easy, so that you can go under surface of the coracoid and you can do a rasping over there. And the rasping is also very important, because
now you can see the nerves properly.
You can see now the musculocutaneous nerve here dead in front of me.
Okay. Now I will be going for the osteotomy.
And you can see the coracoclavicular ligaments directly in front, and that is the end point where we can reach up to there. You can't just peel it off, just you can go up to the coracoclavicular ligament. Now
I am purposefully giving 5 minutes here more.
And we have done a study now for these coracoids. Now, Indian coracoids, if you'll see, it's far more smaller. So we have advised the Depumitek people to make the zigs slightly smaller than what we are having now, because in few patients we have faced some problems and where we have to place one screw in for in initial my 10 cases. I'll show you. I'll share with you. And after this, the coracoid preparation is also very important.
Now, if you see this, I have just this is the take now, and I used to take the.
Now, if you'll see, we are marking it from the H portal. From the H portal, we are putting the needle.
Now, if you'll see, my pump pressure is only 30. That's why. If you'll see, let's see, it is having proper, and I am putting that for that, because on a CT scan, I have seen how much width is there, and accordingly, we have put it.
Okay.
Alpha, beta,
and anyway, this wires where it is exiting in the subscap muscle.
Okay.
You can see
or towards the glenoid.
With the help of the curate.
Now, I think this should be okay. Sir, come fast. Wait, slow. Your assistant is very important here. This now, if you'll see, Kishore, Michael, and Vasu, what they are helping me. This go slow, go.
So this is the drilling what we are doing now.
Okay.
The drilling tap is very important. Okay. And then the top hat what we
and do. Believe me, I have used the now recent Arthrex, because today my tech is wherever is it?
You can protect it with the curate below. And then you can put a top hat above that. This top hat, both top hats has to be in a parallel way. Both the top hats are there. Initial 50 cases, we have used both top hats, but now we are not using the top hat for the proximal screw, because in few cases I have seen that some osteolysis is there. That's why now we have stopped using the proximal top hats. And after the coracoid preparation, top hat has been placed. Now the important step is the coracoid osteotomy. What will this coracoid osteotomy for this osteotomy?
For that, now Depumitek is working on this. What they have made now, they are coming up with.
Now, if you can see,
Two screws. They are coming up. Then this problem. This problem will not. This is like.
And then once the under surface has been burred, so that 360-degree burring is there, and we make the like crack fractures what we can do first, and then we are doing the osteotomy. That makes my life very easy, and so that the big what is created further can be prevented. But in spite of that, we get the leak and we have to do the freshening of the graft all the time. And once the osteotomy has been done, you need to maintain your pressure properly, because here most important thing is that the bleeding starts at this stage for at least for 5 to 10 minutes.
Pressure.
And then once the coracoid osteotomy has been done, the freshening of the graft, the beak what we get, that is very important. And then the freshening takes place. This freshening is done with, at present, the double barrel cannula is there in place with the coracoid, and we are coming it from the M portal to hold it, and we are just drilling it from the D portal. So after freshening of the graft, once the graft has been made flat, now we are ready to go between the subscap split and place it in place. So coracoid transfer, what we can do it here is once the freshening of the graft and proper preparation of the graft is very important, because to create a biology is very important here to achieve a good bony healing. And after that, we can place it in between in the two subscap, between the subscap by elevating the stick, and then you can put the two screws. Now, if you see, we have come up with a double barrel cannula inside. And once you have come with a double barrel cannula, you can do your drillings. First put the 2K wires.
Now there is a drill marking over here for me, outside the sleeve also.
And you have to be flush with the with the glenoid, just at the subchondral level.
Has gone through. It's around about seem to be 35 or 34. So I will be putting a 36 screw to be on safer side. Usually Burkhardt has studied on that. Now drill please. Now
Now once we have placed it, very important thing in this is to see that whether your wires exiting posteriorly
parallel to each other.
Parallel to each other.
If you see. Yeah, posterior wires just you can see.
Yes, we can see that nicely.
Okay, that means I am on the right target, as well as we have achieved a proper.
So once this graft has been fixed properly, you can assess the graft. If you need to freshen it up from the medial aspect, you can freshen it up. And
I'll clear it.
You can see for your sling effect, whatever is there. So this is in short what we can share with you. Otherwise, it will take at least 15-20 minutes. So it's a vascularized bone graft. Triple block effect is what we are getting with this. That is a bone block, dynamic stabilization by soft tissue sling, and the dynamic stabilization by the subscap. That is the most important part what we get with the Latarjet. Now, few questions are there in mind what we need to clear it out, like how much duration you take for the surgery. Initial cases, we have done it for 2.5 hours also, but now it's possible to do it within 1 hour 30 minutes or 1 hour 45 minutes for us. Well, it doesn't make any difference if I go up to 2 hours also. But usually now we can finish it in 1 hour 45 minutes. So average irrigation fluid, what we need is 15 liters for this. Is at least 15 liters usually is needed for this. Is yes, extravasation. Whether extravasation makes any difference in the post-op period, definitely patients are having extravasation, ballooned up shoulder you get it, but usually in 3 to 4 days it gets subsided, and absolutely no any harmful for that with the patient. Now, whether double cannulated screws or a single screw for fixation is used almost in my series, if you see 98% times I was able to put the double cannulated screw, but in few patients, like 4 patients, we have used a single screw for fixation, that is like a Bristow type, because I have fractured the coracoid while operating itself. And once the fracture has been done, there is no other option other than putting a Bristol, like a single screw. But even though with a single screw, that patient has done well, and he's doing his all routine activities. Once I have broken all the coracoid in a female patient was there, small coracoid was there. I have broke both the screws. I was not able to pass, and now what to do? In front of me there was no any salvage procedure left. So what I did was I did a hole in the coracoid, in the glenoid, with a 6 mm reamer, as we do for the ACLs, and then I have passed the graft after through the tunnel and put an interference screw over there. But in spite of putting that just with a sling effect, that patient was also doing well. So here, more important thing in Latarjet, why we are doing primary Latarjet, not the primary iliac crest graft, is that this sling effect plays a very important role in Latarjet, what I feel personally. So single screw also we have done, as I said, when we fractured the coracoid through the upper screw hole in initial cases, but now we are able to put 2 screws at least in all cases. Now neurological complication. At present, I have not done any palsy as such for axillary or muscular tenderness now. But yes, altered decreased sensations are seen around the shoulder in few patients, but those get subsided within 2 to 3 months for that. And in every case, we try to see and locate the axillary now. We try to see your musculocutaneous now, so that we can avoid that. Non-union, usually we have seen it in 2 patients, and 2 patients we have seen the non-union, and the fibrous union, you can see we have seen it almost in the 12 to 15 patients we have seen in the fibrous non-union. This fibrous non-union, you can see, but clinically patient is fine with that. So we have not done anything for that. In 2 patients, we have removed the screws also. Because that is causing some problems for him. So we have removed the screws. For non-union, once non-union, then there is no other option left other than the arthroscopic ICBG to do. If patient is having pain, complaints are there, then we can go ahead and do arthroscopic ICBG. I do my arthroscopic ICBG even using the double barrel cannula. What you can see, what I used it for the Latarjet. Same procedure what we do here, but just we don't split the subscap. Definitely in initial cases, yes, I used to think like whether subscap will be the hindrance for me to put the graft up to 5 o'clock. But 5 o'clock, easily it's reachable over there. And once if you start, for that sake, you need to do an internal rotation of the shoulder, as well as you need to give a posterior push for that, as we do, to create space in front of the anterior. And again, the labrum, you can just retract it with the help of the PDS suture, so that easily you can put a iliac crest graft over there. So for iliac crest graft, you harvest the graft and we can place it with the help of the so we can take this, you can see this without splitting the subscap. We are coming from the rotator interval, and once if we enter, my assistant, he has done an internal rotation so that your subscap becomes lax, and then you will be able to reach up to 5 o'clock here. In this case, I was not able to remove the screw, which was placed at 5:30. I am placing this graft at 5 o'clock above that, and from there we can put the screws easily. And you should see whether you are getting a good compression or not here. And once if you get a good compression, and then you can do your bank cards. And this screws, what we are coming up through the, you can see the double barrel cannula. Once if you put, it's very easy thing. You can just put the 2 guide wires, and over the guide wire, you can put the 2 screws for that. Tightening has to be an alternate, like proximal screw and a first screw and second screw. And if you can see the proper alignment we have achieved, and we have achieved a good compression over there. And after achieving a good compression, and from 5 o'clock above, then we can put the bank cards above that, and we can finish the procedure. Now, how we assess our bone block healings are there or not? In each and every case, post-operatively, we do the 3D CT scans and in patients, and 3D CT scan will show you whether that union has occurred or not occurred, whether this placement has been done above 5 o'clock, 2 o'clock, 3 o'clock. In initial cases, we have placed it at 4 o'clock also. Graft, but as our experience increased, now we are able to put it at 5 o'clock properly after making. As I said, the concomitant abnormalities can be treated with this is at the time of the arthroscopic latage, cuff repair, remplissage, or the slab can be dealt with this. Now, few cases, if you see, if like as I showed you, the same case, if you'll see where a glenoid bone loss was there more than and 15% was there, and a large Hill-Sachs lesion was there, bipolar effect was there. We were able to put the 2 screws in this patient, and if you'll see with the post-op, 8 weeks post-op, patient was having full movements with this. Yes, and he was a volleyball player. He was able to go back to the volleyball also. Okay. Aggressive rehab is very important in such patients, what I see. Now, this is the patient, again, 15 times dislocation was there. There was a glenoid bone loss more than 13% to 15%. Large Hill-Sachs was there. Bipolar lesion was there. Again, if you see, it has gone on EA, and we were able to put the 2 screws here, or the 2 screws. Again, if you'll see here, the healing has occurred, and 10 weeks post-op, when the patient comes, he is able to do his movements. So here, Bristol's was done in 1 patient. As I said, in my 4 patients, we did a single screw. Hill-Sachs was there, glenoid bone loss was there, and the very poor quality capsule was there. In such patient, again, what we did was the latage in such patients. And we were able to put just a single screw in this patient, and as I said, at 5 o'clock. And that patient, even if you'll see, when he came after 8 weeks, he was able to do push-ups also for that. So even patient with 7 dislocations, capsule was badly worn in this patient, and large Hill-Sachs was there. You can see a clear-cut line was there. Here, it was almost more than 20% was there. I was thinking, I was in dilemma to do even iliac crest bone graft here, but we opted the arthroscopic latage, and after doing the arthroscopic latage, again, patient was having good range of and the movements. So post-operatively, what we do is we do give a sling for the 4 weeks, table slides and pendulum day exercises. Day 1, we start. After 1 month, abduction exercises started. And after 1.5 months, if you see the strengthening exercises, what we start. And once the graft has been healed and proper rehab has been done, patient or a sports person can go back to the sports. So in short, I would like to say, like, it's a safe and a reproducible procedure which gives a good results, better visualization of anatomy, more precise graft positioning, and the concomitant abnormalities can be treated with this. And I will suggest the freshers, they will need the cadaveric workshops has to be attended or done before or opting for such type of procedure. Thank you. Thank you.
Thank you, Dr. Samir. That was a wonderful talk, and you described almost all aspects of latage. Since we have 2 other topics, but then one is a knee topic and by the case presentations. Let's go for the discussion now. Are there any questions from the viewers? Dr. Naresh, I can't see the chat box. So to start the discussion, let me ask you, for a beginner, what are the most difficult aspects of latage you should be thinking about? As you said, a cadaveric workshop definitely would be useful. And is it the portal placement, or is it the fluid management, the extravasation of fluid or loss of fluid, or is it the nerve dissection? Is it required, or is it the anesthesiologist?
Yeah, very important thing what you asked. First thing is that regarding extravasation. So for that, always the pump pressure has to be at least 30 when you begin. And always you try to maintain that same 30 mm of Hg. Otherwise, once if you start doing it with a 60 mm of HG and then you'll end up doing 80 to 90, then there will be a ballooning of the shoulder, and within 1 hour, 1.5 hours, you have to complete your case.
Yeah.
In short, I would like to say, like, as the procedure goes on ahead, after 1.5 hours, it becomes difficult to visualize the case. And the real crux is there. Once if you do a coracoid osteotomy and you have to place the graft, that time, then it becomes a juggle. That's why you have to be in time. We decide like within 10 minutes, I'll prepare my step one. After that 10 minutes, I'll go ahead and do my coracoid preparation. Next 10 minutes, I'll be going ahead. After 10 minutes, my assistant tells, sir, 11 minutes ho gaya. So that has to be there while doing, so that you will reach up to the 1 hour 45 minutes. This is regarding the extravasation and timing, what you asked. Second thing, for beginners, what I will suggest, first they should start doing the subscap repairs in beach chair position. Once if they start doing the subscap repairs in beach chair position, they will be able to reach anteriorly, and anterior aspect they can visualize properly. Once the anatomy of the anterior part, like coracoid, where the sling is there, conjoint tendon is there, where the subscap is there, where the axillary nerve is there. Really, axillary nerve and musculocutaneous nerve, not necessary to dissect, but at least you should know where it is, so that while doing the dissection, it should not be a neurological problem post-operatively, what I feel. So initially, even when I started doing with subscaps. After doing the subscaps, I got the idea, rough idea about that. And then slowly I started doing the arthroscopic way.
Another surgery which probably can help in dissection there is the AC joint fixation.
Yes,
You can dissect under the coracoid. Yeah.
Under coracoid, you can reach over there. Then you can start doing AC joint dog button or anything else, whatever is needed.
That was a very important point you said. You shouldn't try to fight blood pressure with pump pressure. That is a very important point in lateral especially, and every shoulder surgery. So the anesthesiologist should understand that a hypotensive anesthesia is very important. And all these patients are usually young, 30s, 20s. So the BP can easily be kept low even in a good BJ position. And the BP has to be around 80 systolic. That is what the anesthesiologist should understand in their mind, especially when you're operating in a different center than yours. It will be difficult to get the anesthesiologist to concur with your requirement. So make them understand the requirement, and then keep the BP or the pump pressure very low. 30 is ideal, as you rightly said.
Totally agree with you, because anesthesiologist plays very important role here. Because if my anesthesiologist is there, I am comfortable over there. So as you said, we should initially just talk with the anesthetist and make him comfortable that we need 80 to 90 systolic. That's all what we can do.
Another question, you said you modified the jig of MyTech to reduce the distance. The distance I feel is around 11 millimeters as I measured, 10 to 11 millimeters. So how much have you reduced, and have you changed the double channel as well?
We have not reduced it yet. We have returned letter to the deputy synthesis, and now they are in a procedure for Indian patients. They are preparing a alpha beta zig, where the distance between these two screws, 11 mm, they are reducing it to 10 or 9, might be. That might help us so that medially, in 1 or 2 cases, what has happened, I have to peel off the coracoclavicular ligament. Once if I peel off, doesn't matter, but clinically it doesn't make any difference, even though if I'm peel off, I am doing, because it heals up within 2 weeks over there. But still, why to do that? That's why if coracoid length is enough, then we can go ahead and do easily this osteotomy.
Another one last question from me. When you've done coracoid as well as iliac crest, and people are doing the scapula spine, the distal clavicle for anterior bone loss reconstruction. So, what is the main difference you feel in the quality of the bone? You said you believe in the dynamic sling effect, just like I do. And what is the difference in the graft, and which one would you say is more easier, comfortable to do?
More like if somebody asked me which graft you will take, like I would suggest a iliac crest bone graft, because the pattern of the iliac crest graft, if you'll see the inner table, that inner table suits with your glenoid, the surface itself. So that gives me a more confidence, like that congruent arc like preparation, you can do it over there. We can put the screws. That is the first point. Second point, iliac crest bone graft is good for integration also. Integration of the graft, if you'll see, it's very good with iliac crest graft. We are using it day in, day out. It's easy for me to counsel the patient also. And even post-operatively, patient has less complaints for that. Other grafts like scapular spine is not that good graft, what I feel, because it's not so hard. You can do it with a small bone loss, or if you're doing, there are some certain papers which I've seen. But now the Joe DBA has come up with a clavicle graft, if you can see. They are doing it with a clavicle graft, and that clavicle graft is also promising. But again, we have to harvest it from there, and then that will be again, we have to counsel the patient. So out of these three, if you ask me, I am comfortable with iliac crest bone graft.
Dr. Samir, I want to add one more question.
Yeah.
You have enumerated a few complications. In your initial days, which is the most common complication you are encountering, and nowadays, how you are handling it?
First main important complication is coracoid fracture.
Okay.
That is the main important thing, what we should avoid it. Second thing, with experience, once if you start doing the 10 Latages, 11 Latages, that will come down, definitely, I'll tell you. But our coracoids are different from the Europeans as well as Americans. Our coracoids are osteoporotic. They are not as tough as their coracoids. We have to think something different way for that. That is the first thing, complication we should avoid. Second thing is neurological complication. I have seen neurological complications came to me when open Latages has been done outside, and they come to me asking what has to be done now. It's a very difficult thing to treat. Once if you do the injury, that's for, I think you can't come out of that. So these two things what are very important according to me. And third is the time management, what you should do it. Otherwise, you have to open it and do it.
Right.
And opening is also again difficult, because once the extravasation starts, it starts like ballooning. And then again, it is difficult to do it.
For me also, the commonest, as you said, was fracture. Another funny complication I had was hair loss. Alopecia, because of a long surgical procedure. In the first few cases, patient had patchy alopecia, which went on for almost 5 to 6 months, and they all grew back. Basically, positioning for 4 hours in wheelchair. The first initial cases. Yeah.
Initial cases, yeah.
Amir sir, one question was there from the chat box by Dr. Mojamul Siddiqui. He was asking, what is the meaning of a top hat? Its function is similar to a washer. How is it different from a washer?
No, it's like a washer itself. It's like a washer, and it will give. Why this top hat has been discovered is Laurent Lafosse. He says like it protects the graft while drilling. First, initially when he started, but future of this top hat is like now he has stopped using the proximal screw top hat, and even we are not using now proximal screw top hat, because the osteolysis usually what we see on the CT scans is seen more on the proximal aspect, and that top hat, that's why we have stopped using the top hat. That can be one reason. Second thing, less blood supply to the proximal part from the conjoint sling what we are having. I think that's why now top hat we have stopped, and it works similar to the washer what we are having, or a plate, somebody is using the plate for compression. So here just top hat has been devised just to protect the graft.
Thank you, sir.
Sir, can I ask one question?
Yeah.
Yeah, sir, the double barrel cannula that you showed, it is from which company? It comes from a particular company or?
Yeah, it's a Depumitic made. It's a Depumitic made double barrel cannula. What we can use it for both iliac crest ICBG as well as Lataji if you want. One question I would like to ask to Sujit now, like as he's doing Lataji is using the buttons, I think, right? Encirclage buttons. And what does he feel like? Screws are better or buttons are better?
Screws, I would say, are much faster to do and more predictable. If my OT list is very long, I would always go for the screw method because more predictable. You have the double barrel cannula to push it in. It holds the graft well, and you've got the two screws to hold the graft, and it's a very predictable and it goes quite fast. The tapes, I wanted to try out tapes. The thing is to avoid metals. And when I read about Hakim's paper of not having the metal complications, like when the osteolysis happens in the beta hole area, the screw becomes prominent, and this tape, when it heals, actually gives a very soft thing and it looks sexy on the x-ray. That is the reason I started, as Dr. Ashish says, the reason I started using the tape. But then tape, when you tension it, is as good as the screws. It holds really well. And the button method is much, again, faster, like the screw, because it's a single drill hole and you got the tape and the button which holds the coracoid, and the concern about osteolysis or cracking of the coracoid will not be there when you use the button in the front. Just like the screw, it will have this button, but it's very small. It won't jut outside. Just like the screw head, slightly larger. It's about 6 millimeters. It holds the graft. The graft is about 8 millimeters, 7 to 8 millimeters wide. So the time wise, I would say I would always go for the screw. But then just for the fun of it, I do all three. I give the options to the patient. The tape, I always say it takes an hour longer sometimes because it takes 8 times of tensioning. We need to have a good assistant to do the
Anterior as
tension.
well as posterior.
Yeah, posterior. It's from posterior. But the advantage of that technique is not the tape. The drilling from the posterior side, I always feel the drill holes go parallel to the glenoid face than in the anterior double cannula method, where the screws can go medially if your M portal is slightly wrong. And another thing, yeah, especially in the
So
initial case.
that's it. For these things, this now we have modified a bit for that. Now this video what I shared now, it's pretty old. So what we are doing now is, once split has been made, osteotomy has been done. After that, before directly taking the graft over there to the anterior aspect of the glenoid, you can drill first holes over there with the help of the alpha beta zig or a double barrel cannula, so
Okay.
that gives you a proper room to place your graft parallel to the glenoid surface.
Okay.
And that you can try it out like now. First, you can drill the hole, distal hole, keep it over there, pass a guide wire from posterior aspect because cannula is there with that. Passing the guide wire, you can just do like as a Sikh kebab. That over the guide wire, you can put the graft and just insert it inside. This is the new what now even Laurent Lafosse has started doing it.
Okay.
So you can just do a Sikh kebab and enter inside over the anterior aspect of the glenoid. That will make your life much easier.
Okay.
My question is to Dr. Samir. So as you said, like before, you used to put graft on at 4 o'clock position, then you like went down at 5 and all. So what is the exact what trick, anything like to measure the placement of coracoid like intraoperatively, and
Yes.
the step of coracoid?
First thing is that when I'm preparing a glenoid bed, initially, I do a marking with the help of the RF at roughly 5 o'clock position. That my RF marking will guide me when I come from anterior aspect. This is the first point. Second point, when we are doing now, when we are placing a graft, we come with one stick from the J portal and place it, or I portal, sorry, J portal or I portal. If I'm viewing through the I portal, I come from the J portal. If I'm viewing from the J portal, I will come from the I portal, vice versa, and put one stick in the inferior aspect of the glenoid. If I'm placing a stick in the inferior aspect of the glenoid, I know that that is a 6 o'clock position. Above that, I can place a 5 o'clock position graft. That will help you a lot for that. Otherwise, sometimes once that, as I said, the extravasation is there, more fluid is there, it's difficult to see now, subscap is coming in between this. This time, like if you put this one stick below and one stick above is holding the subscap above superiorly, that will just distract everything and glenoid will be there in front of you. This is the one thing. Second thing, Smith and Nephew has come up with excellent instrument. What they are doing is subscap splitter, but it costs more than 4 lakh, just that splitter. So they are not having their in their sets. That splitter, if you are having that splits almost up to the 3 to 4, 2 centimeter at least, you can say it splits. Splitter is useful, and then you can put the graft into it. And I place my graft at 5 o'clock, 5:30 to 5 o'clock, not at 6 o'clock, because in few patients I have seen, when I place my inferior screw, it's almost flush to the my distal part of the glenoid. So I just want to have a good purchase as in both the cortices. That's why now I'm coming at 5 o'clock. Is it clear?
Yes, sir. Thank you.
Yeah.
I think we should go to the next talk.
Yes.
The case presentation.
I will stop.
Yeah. Shall we invite Dr. Abhijit Sen for talking the case presentation on physeal sparing ACL reconstruction in an 8-year-old child?
Yes. May I share my slide?
Yes, please.
Yeah. Abhijit, you can go ahead.
Good evening, everyone. I am Dr. Abhijit Sen. Today, I am going to present a case of physeal sparing ACL reconstruction in an 8-year-old child. So, ACL injury was once considered to be very rare in skeletally immature population, but with increased participation of children in competitive sports activities has landed up with the increased incidence of ACL injury in this population also. And also there is increased awareness of the children regarding the ligament injuries, and also year-round training and competition has increased the frequency of diagnosis of ACL injury in pediatric population. So ACL injury treatment is basically a controversial topic, whether there is a controversy whether we should go for ACL reconstruction with open physis or we should delay our ACL reconstruction till skeletal maturity. So there are different studies. Here we can see this study we just published. They have studied the population in two groups. One group was managed with ACL reconstruction before skeletal maturity, and another group was treated after skeletal maturity. And results have shown that those who are in home, they have reconstructed ACL after skeletal maturity, those patients had increased number of meniscal tears and condyle damage, and meniscal tears led to meniscectomies. According to them, at 27 months mean follow-up, the best subjective IKDC score was found in early reconstruction group. So ACL reconstruction before skeletal maturity is a recommended option. So what are the risk factors for ACL reconstruction before skeletal maturity? We all know that the distal femur physis and the proximal tibial physis contribute to the maximum growth of the femur and tibia. It's around 70% and 60% respectively. So as ACL reconstruction leads to drilling of tunnels around the physis of the distal femur and proximal tibia. So in different animal and clinical studies has demonstrated there is disturbance of the growth and there is development of different deformities post-operatively. So if we classify ACL reconstruction pediatric population, there may be three types. One is physeal sparing ACL reconstruction. Another is partial transversal ACL reconstruction, which violates only the tibial physis. And the third one is complete transversal ACL reconstruction, where both tibial and femoral physis are violated. So here is the pictorial demonstration of the these three groups. This physeal sparing, here basically we create bony tunnels through the epiphysis of the distal femur and through the epiphysis of the proximal tibia. And in transfacial group, we try to spare the distal femur physis, and through the tibial physis, we create the bony tunnel. So this partial transfacial may be two types. One is over the top, and another is this transepiphyseal. So in over the top, what it's done, if the loop is created with the graft around this lateral femoral condyle, and this graft is fixed at the metaphyseal region with a screw. Whereas in partial transfacial group, the tunnel is created through the epiphysis only. And the third variety, complete transfacial, is just like adult ACL reconstruction. So what is the general recommendation? So general recommendation is, if the physeal growth is remaining more than 2 years, then we should go for physeal sparing technique. If it's the growth is remaining around 2 years, then we should go for partial transfacial technique. And if the growth is less than 2 years, then we can go with complete transfacial technique. But we should also keep in mind that this study was published in 2016, and they have studied that they have identified 4 pediatric athletes, those who have undergone ACL reconstruction at 14 and 16 years of age, and in case of 2 females at 13 years, 6 months, and 14 years of age, they had developed growth abnormality subsequently. So we should be careful regarding this physeal injury. So here I'll present a case of ACL reconstruction in a 8-year-old child who is athletic, regular athletic activity. And this is the MRI. Here I'll play the video. So clinically, we can see there is Leishman test is positive, and end translation is soft, and pivot shift test is also positive. So during reconstruction, we have put a oblique incision, which is 6 centimeters down from the joint line. We have harvested semitendinosus graft and made it 4-fold, and we have prepared a 8 mm thick graft. What we did different here is we have preserved these needles for further periosteal suturing. So in diagnostic arthroscopy, you can see the ACL is completely gone. So femoral attachment site is cleared with the shaver. Here we created this femoral tunnel, all epiphyseal femoral tunnel with the help of PCL jig from outside in technique. So the between is protected with the help of a curette. So outside in technique was applied for creating the femoral tunnel, and with the help of CM, we have confirmed whether the tunnel is limited to the epiphysis or not. Here we have created the tibial tunnel through the tibial epiphysis, and we have also confirmed with the help of CM. Then graft is passed through the tunnels, and the femoral end of the graft is fixed with the help of a screw. Now the graft is passed through the tibial tunnel, and cycling was done to tension the graft. And then the graft is fixed at the metaphysis with the help of a tibial post. Here, what we did extra, we have sutured the graft with the help of this needle of non-absorbable suture with the periosteum of the tibia. So this is the new ACL reconstructed, and this is the Leishman test after reconstruction. So the postoperative rehabilitation protocol, we have followed same as adult. there is no difference in the post-operative rehabilitation protocol. Here we have follow-up of this patient. We have operated this patient at the age of 8 years, and at the age of 13 years, there is no angular deformity of the knee, and there is no limb length discrepancy, and the patient is doing such kind of athletic activity at present. So my take-home message will be, the ACL tear is not very uncommon in children, and early reconstruction is recommended rather than waiting till the skeletal maturity, as we have found that in the studies, there is increased chances of chondral injury and meniscus injury. And we should try to spare the physis wherever possible. And another very important thing is, parents of the children must be counseled about the potential deformities which may arise out of the ACL reconstruction. Thank you.
Thank you very much, Dr. Abhijit. It was a very nice presentation. Any questions from any of the participants?
Yes. Abhijit?
Yes, sir.
Excellent talk. First, and just I would like to ask, you have done both fascial sparing, na? TBL as well as femoral side.
Yes, sir. As the child is 8 years old, so we have opted for that.
So what difficulty you had while drilling the tibia tunnel?
Sir, actually, we have confirmed with the CM. One difficulty we had that the epiphyses were little bit thin, because there is a chance of injury to the physis when the epiphysis is thin. So we have reconstructed the ACL with 8 mm thick graft. So the physis was around 10 mm. So here one difficulty we have encountered.
Exactly. So at the age of 8 years to 12 years, usually you get the space anteriorly was just 10 mm. So
Yes.
usually it's in the literature said like you should use the graft 7 mm or 8 mm, not more than that.
Yes.
Yes.
Otherwise, chances are there you can coerce the physis also.
Exactly.
Yeah, that is the one thing. Second thing, Siam always we should use for pediatric patients. Even when we are doing pediatric PCLs, we need to use the Siam so that we can avoid the physis.
Yes.
Yeah, very important thing what you did here. And one more paper quoted by Dr. Nishik Shah from Ahmedabad. He's from Ahmedabad. According to him, there is no need to do any transfacial fascial sparing surgery. He has shown his results in almost 14 to 15 patients that transfacial, if you are drilling it dead in the center for the tibia, at least for the tibia, he didn't have any other problems with transfacial doing.
Yes, sir. In that case, we should make the tibial tunnel as perpendicular to the physis as possible, because in that way, the area of damage to the physis will be less. If we create a oblique tunnel, then the cross-section area of the damage will be more. So if we go through the center, then the cross-section of damage will be less.
Okay.
And I feel the important thing is not to use an interference screw there, crossing
Yes.
the physis, isn't it? Which can
Yes,
act
yes.
as an epivasive disease.
Yes, sir. Metaphyseal
So-
fixation is preferred in that case.
Drilling alone will not cause damage, as Dr. Samir rightly said.
One more question from my side. You did add suturing of the periosteum over the screw. Was there any advantage of that?
Actually, we know that the periosteum of the children is very thick. So we just had a supplementary fixation with that only. We had taken the advantage of this thick periosteum and use that as a supplementary fixation.
Right. Thank you.
But let me ask the panel, given the option of all inside reconstruction, so which one would you choose? And Dr. Abhijit, can you put in your views on that?
But actually, I don't have much experience with the all inside technique, so I generally
The only thing is the physial drilling will be a smaller channel. We'll have a 4 mm drill hole instead of 8 or 9. That's the only difference.
Yes.
But then again, probably a little edge on that. But your technique was very good. You demonstrated very well. Good videos.
Thanks.
Sujit sir, then in
Yes.
that case, if we do all inside ACL, then how much would be the tibial socket? 10 mm or less than?
Yeah, maybe 10.
Yeah.
Graft has to be short. Yeah, the socket has to be short, and the graft inside the tunnel maybe 8 or 10. The socket can be maybe 15 maximum.
Yeah, that depends case to case.
Case to case, correct. And the size of the patient. 8 is a very small child.
When we are doing fascial sparing, very important thing is there from CT scan, we should find out how much space is there anteriorly. 10 mm, 9 mm or 11 mm. Usually we get 10 to 11 mm, not more than that for a drill. So at that time, very important thing is that we should use the graft of 8 mm, not more than that.
Right. Any more questions? Anyone?
Can we go to the next case presentation?
Yeah.
I think we should move.
I invite Dr. Tushar Doke to present about neglected shoulder dislocation. Over to you, Dr. Tushar.
That should be interesting.
Yeah.
Hello, good evening, everyone. Today I'm going to present one case of neglected posterior shoulder dislocation operated with modified McLaughlin's procedure. So instability, some basics like unable to maintain the humeral head in glenoid fossa. So there could be dislocation, subluxation, and along with that there could be only laxity which causes this kind of instability. There are multiple causes for that, like acute or repeated trauma, repeated overhead activities, or overhead activities that require abduction, external abduction. So basic anatomy is like it's a kind of ball and socket joint, with glenoid making 1/3 of size of humeral head and labrum, which increases depth by 50%. So it is kind of golf ball phenomena. My boss used to say. So this big head sitting on small circular area. So to increase the stability of the shoulder joint, we have multiple stabilizers, static and dynamic. So static stabilizers, which are like glenoid labrum and joint capsule, and dynamic stabilizers, rotator cuff muscles, periscapular muscles. So they have their unique role in shoulder stability, like labrum deepens the glenoid fossa and cause concavity compression effect. Joint capsule maintains the negative pressure inside the joint, while dynamic stabilize the rotator cuff. They maintain a humeral head in glenoid fossa throughout the range. There are multiple types of instability, anterior, posterior, multidirectional. There are so many classifications depend on degree, frequency, and etiology and direction of the cause and instability. Some basic classification like Madsen's classification, Gerber's classification. So there are some basic tests in OPD basis like apprehension test, job cushion test, load and shift test. So today my topic like about posterior dislocation of shoulder. So it is kind of rare injury, accounts for 4% of all shoulder dislocation. Along with that, there comes one fracture which called Hill-Sachs lesion or malignant fractures. Up to 7 to 10% of cases, diagnosis is made only once it becomes chronic and locked. When one patient starts, there will be mild pain. So there are mechanism injuries most common like fall on abducted and external shoulder. Second is we see usually some patient with history of epilepsy or electric shock. In those patients, usually we have our internal rotator muscle which are stronger, we contract with greater force than external rotors. So on examination, clinically first we see like appearance of posterior fullness. In acute dislocation, patient have anterior posterior shoulder pain with restricted movements. If it is mild pain, then it indicates chronic dislocation, and sometimes it may resemble frozen shoulder or shoulder sprain or rotator cuff tear. When humeral head defects engages in posterior glenoid, preventing dislocation, then it is called lock dislocation. So in physical examination, there will be prominence of coracoid process, arm fixed in internal rotation, and complaints of restricted active and passive external rotation. The restriction of abduction and flexion usually between 75 to 100 degree. There are multiple specific tests when the patient is unable to supinate the forearm when arm is forward flexed. On radiologically, we have some specific sign for posterior dislocation such as vacant glenoid sign, light bulb sign, rim sign when there is more than 6 mm distance between humeral head and anterior glenoid head, and thorough line sign. So treatment option is depend on etiology, depend on head defect, and depend on patient requirement. It could be conservative close reduction or supervised neglect in case of patient has having less demands, old age patients, and operative in case of like open reduction, subscap transfer with lesser tuberosity. The decision making is made basically on the size of articular cartilage injury of humeral head in percentage, like less than 25%, 25 to 50%, more than 50%. So less than 25% and acute or fresh injury, it comes usually in close reduction. When it is more than 3 weeks, it doesn't come usually in close, then needs open reduction. Sometimes it is unstable, then we do subscap transfer. Then if defect is between 25 to 50%, then there will be transfer of subscap with or without lesser tuberosity more than 50%. Then patient usually requires arthroplasty. So one 35-year-old delivery boy came with complaints of inability to extend, rotate, forward flex, and abduction of arm since 3 months. He is having history of RT with fall from bike, and he took primary treatment from some local quack. Then he came to us. He was having 40% of humeral head defect with reverse heel sac. These are MRI findings. Unfortunately, I couldn't get CT scan. The CT scan is basically used for exact location and size of defect. Axial sequences usually help. MRI also helps to evaluate other injuries like rotator cuff or slap injuries. So clinically, patient was having range of motion preoperatively. We did supine position with interscalene block. Then we use normal standard deltopectoral approach. Instead starts above coracoid, then it goes laterally up to proximal humerus. Then we clear the adhesions of subscap. We rotate an external, we internal and external to assist the subscap. Also, then we go for LT osteotomy. So LT osteotomy starts usually from lower border of LT. So to check that it comes around about half the thickness of LT, the subscap. So after This is then after LT osteotomy, we reduce the head with distraction and external rotation. Same time, we check and assess the heel sac defect and what we have seen in the city, whether we are getting same thing in intraoperatively. Also, we prepared the bed of heel sac defect to further transfer of LT. So basically, it is lock dislocation there. So there was so many adhesions was there on heel sac defect, so that we should be clearing to LT to finally heal. Then that we repaired with double row technique with medial row. I put two triple loaded anchor and I took bite with as it is LT and along with subscribe. So I used bird beak to take the bites. Then I use normal lateral row anchor to reduce and fix the LT. So in top, after fixation, patient final range of motion, what we got on table, what we achieved on table. As seeing the patient is able to extend rotary. Then rehab protocol, like for 4 weeks, we kept the patient immobilized in neutral position using shoulder support. Internal and external rotation movement restricted, while hand and wrist mobilization started. After that, we started physical therapy with passive range of motion first, forward flexion, external rotation slowly, and total activity. The patient resumed. It took around 3 months. Then it is patient came to this is 3 month post-op X-ray. These are the patient's final range of motion. Like at the end of 4 months, we got. Now he has resumed his work. He's driving the bike. He's doing his all activities, and he's happy whatever range of motion he has got. Thank you.
Thank you, Dr. Tushar. It was a nice presentation. Any questions from the panel?
Tushar, very good presentation. Like an good result what you have achieved after such neglected shoulder dislocation. Just I want to know few tips and tricks from you, how you would reduce that neglected head. What instruments you have used for that? Because
After
you can say
LT, so after LT osteotomy, there was not much difficulty while reducing. Just I like axial traction and extrudation, but while reducing that, I had to become slightly slow because it may further damage the cartilage while reducing. So, and as patient came late, we didn't try for close reduction, like as I said, like 3 months. So, in fact, after LT osteotomy, there was not much difficulty while reducing.
because Pascal Bailo has come up with one instrument, curved instrument like what we are having a Homan's type. That curved instrument he has come up and he places it on the posterior aspect of the glenoid and then he tries to reduce it with that.
Okay.
Our simple instrument can do that. But
next case, I will try to get a Pascal instrument about this.
But it was easier for you, no? There no need.
Yes, yes.
Sujit, anything else?
Yeah, it was wonderful, nicely done, nicely executed. Posterior dislocations can be difficult, especially when it's neglected and old, and the results are good. Dr. Samir, can you give some insight on reverse remplissage for posterior dislocation? Any experience on that?
Yes. Reverse. In fact, reverse remplissage, if you see, the what we are doing, the remplissage, is similarity what we have to recreate over there. For that sake, what we do in remplissage, but very few cases even we need to do it, because even after reducing it, posterior repair has been done. Very minimal bank hill sacks what we get. If we get that hill sacks, what we do, we try to put a triple loaded anchor over there, triple loaded anchor in that defect, and that defect also you have to be a single row repair what we are doing for that, and you need to pass the sutures through the subscap, and you try to fix it into it as we are doing now ASA, what we say, like arthroscopic subscapularis augmentation what we do, a similar type what we can do it and try to fix it. Definitely that will help.
Sir, my question to Samir sir and Sujit sir, like I presented one posterior lock dislocation, whether you have encountered any anterior lock dislocation which is chronic. So in that case, how you will proceed for heel sag defect in lock anterior dislocation? But because I don't think that lock anterior dislocation will come with arthroscopically. So I think we must have we should be reducing it open. So for that heel sacs fixation, what we will do?
If it's a acute lock dislocation, it is not it shouldn't be difficult. You're talking about chronic one, isn't it? More than 3 weeks. Yeah. So in that case, it will be the subscap tightness which is the most difficult to correct, and it mostly will not respond to close reduction, and you may have to respond to open reduction. I had a case of an older lady with an old lock dislocation, about 4 months old, and she had osteoarthritis and supraspinatus stone. There was no confusion. I went ahead with the reverse shoulder and getting it back in a younger patient. Having said that, in a younger patient with a lock dislocation, you have to think about you have to assess the amount of bone loss, especially the humeral head bone loss. If it's a large defect on the humeral side, you have to address that as well. Otherwise, an open reduction and stabilization, anterior stabilization can help.
So then, what you will do for sir heel sag defect for that? In that case, I was.
Yeah, smaller hill sacks they can be dealt with in open technique. You can make a posterior approach for the shoulder for the humeral head, and you can do you can think about even a bone graft or a remplissage on the posterior aspect.
So you mean to say, sir, we will open from anterior and posterior both aspects?
You have to plan or a transdeltoid for the hill sacks in the posterior aspect, but that is a rarity. You stabilizing the anterior part will usually keep the shoulder in. And yesterday, a case Dr. Sanjay Desai was showing in Arthroscopy Academy, locked anterior dislocation, isn't it? And conservative was the option. If the patient is not symptomatic, patient is coming back after 18 months. That case was 18-month old, and go conservative. The results are bad.
What is your experience, Samir sir?
Yeah, I'll tell you. Such cases are first very difficult to deal with. Subscap tightness is there and all. I do stage wise in these cases. First, I will just try to reduce it from anterior aspect, do the reduction for that. In 3 cases we have done. Reduce it, gain some moment for that. And after gaining the moment, and if reduction is well, then you can go ahead in the second stage, do the scopy. Then you will find out whether remplissage is needed or not needed, whether it's trying to get distributed. But usually, out of 7 cases what we have done up till now, only 1 case we intervene and we did the remplissage for that. Otherwise, it was not needed in 6 cases, even though we have done second stage scopy for that. Otherwise, what it becomes meshy when we try to do it in 1 stage. It becomes meshy, like we have to dissect it again. We have to go it from the posterior aspect, and then so it's a better way. But anyway, surgeon's choice.
Thank you, sir.
Anything else?
Thank you.
Is it the answer what you wanted, or anything else you will do for that?
Sir, the same case I discussed with in morning in Arthroscopy Academy. So one of the senior surgeon told like he said like he will open reduce, and same time as the kind of derotation osteotomy, he will expose the heel sacks. He will put the anchor in heel sacks, and then he will to take the bite. Only thing he said like he will get knots inside the joints. So I was thinking like whether any other ways to address that. Thank you, sir. Thank you.
Anyway, the experience is less for most of the surgeons. And derotation osteotomy is something you should have in your mind. Yes. That's a good point you raised there.
Sir,
Difficult
I have one
situations you should
question.
have. Yeah. Yes.
Yes, sir. Sir, I have a friend of mine who is having posteriorly locked dislocation, but right now he is at the stage where he is having glenoid side cartilage loss at the posterior aspect. So, what can be the option for him?
Age, duration of the problem?
Sir, duration is around 18 months to 18 months, and age is around 30.
Okay. And there is pain.
Yes, there is pain. He is having a fairly good range of motion, pain on and off, but he is having arthritis. And posterior glenoid is, like there is a bone loss.
It's a difficult
is there.
Yes.
Posterior glenoid bone loss is there, as well as even heel sacks is there for that.
Yes, sir. He is having heel sacks as well.
I hope it's a hypothetical situation.
No, sir. A friend of mine.
Really? Okay.
Thing is that
refer to Dr. Samir.
First thing, because such cases we need to find out whether any bone block is needed, whether we need anything to be done for the cartilage. That things need to be evaluated, I think. So next time you present the case.
But sir, I don't know what to offer him, so that is the reason why I'm asking.
We will offer him. You just present the case.
Okay, sure, sir. Sure.
40 years, 18 months long dislocation with arthritis. That's very bad combination.
Yes, sir.
It's a toughie. It's a toughie. So you cannot give good results anyway. So if we can go conservative, at least for now, that would be the best option.
Yes, best option at present. It will be the best option.
Thank you, sir.
Yeah.
So I think we had wonderful discussions today.
Yeah.
Starting with Dr. Samir's presentation on arthrolethargy from the basics to the advanced. So I think we'll wind up, isn't it?
Yes,
over to Dr.
yes,
Naresh. Yeah.
Yes, sir. Thank you very
Dr.
much. Thank you very much, Dr. Sujit. It was very wonderful presentation by all the participants today. Dr. Samir sir spoke about arthrolethargy along with Dr. Abhijit Sen. Very nice presentation about transepiphyseal, epiphyseal ACL reconstruction. And my friend Dr. Tushar spoke about posterior dislocation of the humeral head. It was a wonderful evening. Thanks. Good night. We'll